So we have our patient here today who has pain in the knee. Now she's already had steroid injections inside the knee, and she's already had hyaluronidase, Synvisc, or other similar type of medications injected in the knee. And we still have pain. And my personal belief, and it's supported, is that you don't want to put steroid in the knee repeatedly, because steroid is great. It can reduce inflammation, but repeated use of steroid, especially around ligaments in the knee, can cause thinning and degeneration. So that's why we're doing this, because we don't want to put the steroid in the knee. So first of all, let's identify which is your bad knee.
Right.
The right knee. And I understand. How long has this been going on, the pain? About 5 months. Okay.
It started recently. It became more intense.
Okay. So the pain has been, getting worse over the past.
A little long, I don't know.
Yeah, more than 5 months. So I always like to examine these together. You can see that clearly there's swelling on this side, and that happens, whether it's a bony swelling, it's arthritic or what have you. But here I can feel a little fluctuation here. So she does have a little bit of a bursitis, and she does have a little bit of probably some fluid in there. And we've looked at that before. So the genicular nerve block is a way of blocking the nerves to the knee without entering the joint. So entering the joint, for example, if we're going to do a steroid injection, what we would do is we would just go right through. Here's the patella here, the bone here. We would go underneath the bone, and we would enter right into the knee joint. However, for her, we're doing a genicular nerve block. So the genicular means knee, and obviously the nerve block. So the way that we're going to do this is we're going to have her in the operating room, have the knee just like this, and we're going to find certain points. These points are basically, if we look here, here's the tibia, fibula, and the lower part of the femur. So the points where the nerve runs, and I'm just going to put a mark here, the nerve runs here, here, and right about here, okay? And imagine putting a needle near your knee. It is uncomfortable. So we are going to make her a little bit sleepy so that she doesn't, have any discomfort. Okay, so these are the points. And I just mark these more for reference than anything else. We're going to put my initials here, site marking, so I know I'm going to do this knee. And one needle is going to go here. One is about here, okay? And I'm just feeling it. I can feel the tibial plateau, the top part of the tibia, and I'm going to go right about here. And that's our general markings for the knee. After we're done, I want you to walk. So the idea is, after I blocked the knee and I made it feel better, she's going to do all the things that normally would make it hurt. Well, it's not going to hurt because I'm making you sleepy, okay? That's why we put a little intravenous. I'll give you a little bit of medication, like you're having a colonoscopy or something, okay?
Okay.
And, I can feel that crackle. Yeah. That hurts. I know that hurts. Why are we doing this? Because, listen, eventually we're all going to get arthritis. There's no way around that, But the idea is, she's not a smoker. She's in an ideal body weight, and this is bothering her. It's now starting to affect her activities of daily living. So at that point, we have a couple of choices. Do we want to rush and do a total knee replacement? Yes, that's an option. However, if we can extend that out as far as possible and maybe even avoid it altogether, because why would she need a total knee replacement? Because of pain. And that's the whole thing. Now, we've tried so many things. We've tried topicals. We've tried the intra-articular steroid. So now it brings up the question, well, how long is this block going to last? And that, I know you asked me that before. Well, I don't know. It lasts as long as it's going to, and we see. Because if it works, and you say, wow, this feels great. I know. And I'm going to test you afterwards. If you say, wow, this feels great, and the pain comes back, I'm going to see you in about a week or two, and you say, oh, wow, you know what? This was so good. Now the pain came back. Don't worry. We do it again. We do it with a slightly different medication, and we test you again. And if that helps and the pain comes back, don't worry. We've tested you twice. Each time it helped, but the pain came back. It's okay. Now we're going to make it last a long time. We're going to burn the nerve. Everyone goes, oh my God, you're going to burn the nerve. I know it sounds pretty harsh. I need to find a better word for it. The better word is really called radiofrequency ablation, where we put a very thin needle here again with a high frequency vibration, and that causes the tissues to get hot. They get hot, the nerve coagulates, and it just splits apart. But just like getting your hair cut, a new nerve grows. How long it takes that new nerve to grow from your spine? A little bit, about the speed of your hair growing. So by the time it grows out, it's about a year. So we're hoping that we can give you a year of relief. Hey, you know, things can change in a year because the nerve, as it grows back, and I always say this very colorfully, the nerve is growing back, it's going back, it reaches its old neighborhood, and it goes, whoa, look at this neighborhood, look at this, my old hood, it looks great, there's a Starbucks, a Dunkin' Donuts, you know. Hey, brain, nothing to report, we're all good, you know. That can happen. Or it can go back to its old neighborhood and go, oh man, nothing changes in this old place. It's still a dump, you know, we still have, you know, whatever franchises that were there before or not, you know. And if that's the case, it's okay. We can do it again. Okay, so we provide some longevity. Okay, do you have any questions? But yeah, better than surgery. I know, right? Listen, not to criticize any of my orthopedic colleagues. That's great. If you need it, you need it.
Yeah.
But you know, if we can manage you without it, you know. Excellent. Okay, I'm going to take you back, and then we'll look at how she does afterwards. I know you said that your pain before was about an 8 out of 10. Yeah. So we're going to see what her pain score is after the procedure. Okay, let's do this.